at the outset, I would like to thank Dr. Kumar Prabhasar and team for giving me this opportunity. So I'll be presenting capematinib in MET exon 14 mutated advanced NSCLC. That is the updated results from the geometry mono-1 study. So in NSCLC, we know that it is reported to be mutually exclusive of the other established molecular drivers like EGFR, ALK, or other translocations. So MET mutation in splice site leading to exon 14 skipping result in mutation was originally discovered in lung cancer and in NSCLC. Again, this MET-X14 mutation occurs in almost 3% of NSCLC adenocarcinomas and 5 to 20% of other NSCLC subset. As you can see in this pie diagram, almost 3%. And this MET-X14 mutations are linked to early stage diagnosis and older age. It is also found to be independent prognostic factor that predicted worse survival compared with patients without MET mutation. As you can see in this Kaplan-Meier survival curve, both OS and DS, with patients having MET mutation, there's decrease in disease-free survival and overall survival. It also responds poor response to immunotherapy, wherein in a retrospective study of 147 patients with MET, patients who received immunotherapy were valuable for response. And you can see that the overall response rate is just 17%, whereas the median PFS is 1.9 months and median OS is 18.2 months. So this individual case report suggests that Pembro might not be effective for NSCLC with high PD-L1 expression and MET-X14 So also this MET inhibition prolongs survival in MET mutated stage 4 NSCLC. There's again a retrospective study where patients with MET mutated who were treated with a MET inhibitor had prolonged survival compared with those treated with other therapies. You can again see the overall survival in MET mutated stage 4 NSCLC patient was 8.1 months for patient who never received a MET TKI, whereas it was almost 10.5 months for patient with MET mutation only and 5.2 months for patient with MET mutation concurrent amplification. So 24.6 months for patient who received a MET TKI, either crizotinib, glestatinib or capmatinib. So you can see there's definite improvement. This capmatinib, it is basically a selective MET inhibitor, which is an oral ATP competitive, highly potent, selective and reversible inhibitor of MET kinase. It has more than 10-fold selectivity for MET receptor kinase when assessed against a panel of 55 other kinases. It crosses the blood-brain barrier, showing preliminary brain activity, and it is also a potent blockade of MET activation, cell-based function, biochemical assays. And if we compare with other agents, it is the most potent inhibitor against MET-X14, as you can see in this IC50 mammograph. So mono-1 study, you can see basically this is a multi-center open-label phase 2 trial which evaluates the efficacy and safety of single-agent capmatinib in adults. So what they did is they divided the patients with stage 3B or 4 NSCLC into 6 cohorts. Cohort 1 is pre-treated, cohort 2 pre-treated with patient MET gene copy number more than 4, cohort 3, cohort 4 is pre-treated patient with MET exon 14 regardless of the MET gene copy number. Is again treatment 9. Cohort 6 is pre-treated with either MET TCN more than 10 without MET-X14, and cohort 7 is treated with MET-X14 regardless of the MET gene copy number. So the primary objective of this initial mono-1 study was overall response rate, whereas the secondary objective was duration of response, and other secondary objective is overall response and duration of response assessed by investigator, whereas both the initial two were by blinded independent review committee. For geometry mono-1 data, that is efficacy data for cohort 4 and cohort 5, which are basically treatment pre-treated patient with MET-X14 and treatment naive patient. You can see there's definite overall response rate of 40.6% in BIRC assessment as compared to 43.5 in the investigator assessed overall response rate, whereas the disease control rate is 78.3 versus 76.8. And this is in pre-treated cohort 14 mutation. So there's clinically meaningful response for observed. There's also observed clinically meaningful response in treatment naive patient with MET-X14 advanced NSCLC. As you can see, the overall response rate is almost 60. In BIRC, this blinded versus 60.7 months in investigator. Again, the disease control rate is similar. There's also deeper response observed in majority of patients across both cohort 4 and cohort 5B. And the median duration of response was 9.7 months in cohort 5B. Median PFS was 5.42 in cohort 4 and 12.42. Also, they have confirmed that there's this capmatinib also has a confirmed activity against brain metastasis, as can be shown here that almost 54% had an intracranial response, with 4% had complete resolution in all brain lesions, and of the remaining 3, 1 had complete resolution in 3 lesions, stable in 4, like this. So almost 12 out of 13 patients had intracranial control. So this basically capmatinib met exon 14 mutated advanced NSCLC. On this geometry mono-1 study. So what they did is that capmatinib 400 BT, they evaluated the cohort 4, which is the METX 14, treatment naive cohort 5B, and pre-treated naive expansion cohort 7, where there's METX 14 was there with any G copy number. And there are total 32 in this term. So the primary endpoint of this updated response rate by blinded independent review committee, whereas the secondary endpoint is disease control rate and disease control rate, whereas the secondary endpoint is overall response rate and disease control rate, TTR, OS, safety, and pharmacokinetics. So you can see this very high overall response rate and disease control rate in treatment naive patient from cohort 5B was confirmed in the expansion cohort 7. So you can see overall response rate is 67.9 in BIRC, whereas in it is 65.6%. Whereas the disease control rate is 96.4 in BIRC as compared to almost 100% in cohort 7 who are treatment naive. So it's consistent response between BIRC and investigator assessment in treatment naive patients with METX 14 in cohort 5B, where they are pre-treated. Also, 51.6%, 40.6% response rate for patients in second and third line respectively. So you can see this higher overall response rate and disease control in the second line setting in the expansion cohort 6. There's almost 44% overall response rate in all 100 patients. Again, you can see in cohort 4 where the patient received second line or third line, overall response rate is 40.6 as per BIRC, and investigator assess 42, whereas the disease control rate is 78.3 and cohort 6 it is almost 90.3. So rapid and durable response was observed irrespective of the line of therapy, and in patient with response to capmatinib, the majority of response occurred with treatment. The median duration of response to capmatinib was 12.7 months in second and third line. Also, if we see the median PFS, it is almost 12.3 months in the first line, 6.9 months in second line, and almost 5.4 months in second or third line. So the majority of the patient experienced a tumor response at first evaluation after initiating capmatinib with a durable response. A clinically meaningful median overall survival of 12 months in first line in cohort 5B and 13.6 months in second and third line was observed. As you can see in cohort 4 with pre-treated, the median OS is almost 13.6 months, whereas in treatment cohort 5B with treatment naive, a median overall response of 20.8 months, which is excellent. So also, if we see the toxicity part, peripheral edema, GI symptoms and increased blood creatinine were the most frequent adverse event, and you can see that almost 54.2% of the patient has this peripheral edema. Nausea in almost 7 are comparable to those previously reported for cohort 5B with 67.9% overall response rate both in treatment naive and METX 14 NSCLC. In pre-treated patient, the overall was 51.6 in second line and 40.6 in second or third line. This clinically meaningful median OS of 20.8 months and 13.6 months were observed in treatment naive and pre-treated cohort 4 respectively, demonstrating a long-term survival benefit of capmatinib in these patient population. And the manageable safety profile of capmatinib remains unchanged based on the updated safety and results from the geometry mono-1 study. And the updated results further confirm METX 14 as a targetable oncogenic driver in NSCLC and strengthen the evidence for capmatinib as a valuable target treatment option for patients with METX 14 NSCLC. Thank you very much.
Thank you, Dr. Amol, for the crisp presentation. Now